A big hi to everyone, continuing our head injury part 3 with practice MCQs today. Which of the following are true or false regarding scalp and skull? Ring fracture is known as motorcyclist fracture. It is incorrect. The reason is ring fracture occurs around the foramen magnum due to the axial transmission of force during fall from height onto feet or rarely with a severe blow onto the vertex. Scalp lacerations mimic incisions. Yes, it's correct. The reason is scalp is highly dense soft tissue and also it is very firm. At the same time, it is situated over the skull. So with a blunt force trauma, what will happen due to the hard nature and also on the skull on top, it gets splits nicely mimicking an incision. Stellate shaped laceration is caused by a hammer. Yes, it's correct. And also you might get stellate shaped lacerations as well. Pond fractures are seen in adults. It is incorrect. The reason is adult bones are very hard, easily breakable due to the fully ossification. However, in bones of infants, it is thin and very pliable. With the application of force, it gets only a ping pong or just a depression rather than having a depressed type of fracture. So simply speaking, pond fracture is the pediatric counterpart of adult depressed fracture. Trauma-related epilepsy occurs in gutter skull fractures. No, gutter fracture means just a scratching of the superior parts of the skull bone without having any internal injuries. Example, a bullet comes and just glides away along the skull bone, having gut-like erosion there. So you don't get any brain injury. However, with a depressed kind of fracture, you get a brain damage as well, resulting in scarring that could occur later as epileptic attacks. Linear fissure fracture or pointer fracture indicates an application of high velocity. No, it's incorrect. It is due to low velocity. What do you mean by a linear fracture anyway? If this is the skull, if you get a very somewhat moderate or low velocity impact and also the force is a bit widespread or diffused. Example, just fall from a standing height and hit the head on the ground, right? So you get fissure fractures. And at the same time, fissure fractures can get away from the site of impact as well. The reason is the force will be transmitted through the weakest part of the skull bone. If the force is somewhat more and the striking surface is smaller, in this case you might get cobweb fracture. The example is like this. You get multiple radiating fractures as well, and because the force is somewhat more and the force is bit localized. When the force is very much high, all right, and the force is also localized, you get depressed type of fracture, right? Cobweb fracture indicates a localized force. Yes, it's correct, as you can understand. Fissure fractures are more reliable than depressed fractures for locating the impact site. No, it's not, as I have explained earlier. Which of the following is true or false regarding scalp and skull? Crushed hair bulbs indicate application of blunt force trauma. It is correct. The reason is with sharp force trauma you get cut hair bulbs or cut hair. Scalp lacerations bleed more profusely than comparable lacerations elsewhere on the body. Again, it's true. The reason is scalp is very dense and also it has got lots of vessels. With the split laceration, what will happen? The vessels can't retract when compared to the other places of the body because of the dense nature of the scalp and also with the high vascularity. So as a result, it is correct. A hinge fracture is due to the application of axial force. No, axial force causes ring fracture, as we have described earlier, a hinge fracture is caused by lateral force application onto the side of the head, as in high impact motorcycle riders. So this is incorrect. A pond fracture is the pediatric counterpart of an adult depressed skull fracture. Yes, it is correct. A black-eye periorbital ecchymosis only occurs from local impact. No, it is incorrect. The reason is we know there are three well-known mechanisms causing periorbital hematoma. The first one is direct lobe. Second one is anterior cranial fossa or fossae fracture. And the third mechanism is seepage of blood with the injuries over the forehead, either in the form of contusions or maybe lacerations. Raccoon eyes indicates anterior cranial fossa fracture. Yes, it's correct. Battle sign is a key indicator of mastoid process fracture. No, battle sign is a key indicator of posterior cranial fossa fracture. Battle sign indicates posterior cranial fossa fracture. Yes, it is correct. This one is incorrect. Regarding skull fractures, fissure fractures are caused by localized small surface high force trauma. It is incorrect. The reason is usually we get fissure fractures with diffuse low or moderate impact. A fissure fracture starts exactly at the point of force application, and the next one is fissure fractures may start away from the impact. Now please know about this description. I also can't give an exact answer. Fissure fractures usually starts at the point, a little bit away from the point, and also much away from the point of impact as well, since the fracture line extends along the weaker parts of the skull bone. So as a result, I don't know what to tell about that part. You have to know each and everything that I have explained. Fissure fractures usually produce a sunken or depressed area of bone. No, it is just a linear fracture, no depression at all. So here this is incorrect. Depressed fractures are caused by low energy broad surface trauma. No, it is incorrect. It is caused by high energy smaller surface trauma. Cobweb fractures occur due to broad flat surface trauma. No, it is again localized small surface area. So again this is incorrect. Pape's rule states that the fracture lines radiate outward from the point of impact. It is incorrect. Pape's rule actually mentions regarding two impacts. If this is the first impact, and the second impact is this one, if you get a fracture line like this with the first impact, you with the second impact also you get another fracture line, it is going to stop at this line because it can't cross the already fractured area. So Pape's rule actually states about the sequence of impacts. So this is incorrect. Regarding brain contusions and lacerations, a vessel damage occur in contusions caused by trauma. Yes, by definition, contusion is extravasation, coagulation and infiltration of blood due to blunt force trauma. The same definition is applied to the brain matter as well. So this is correct. Lacerations can extend bleeding into the ventricles. Yes. Burst lobes lead to subdural hemorrhage. Yes, that is intracerebral hemorrhage by bursting the lobe can lead up to the subdural space, leading into subdural hemorrhages. Cortical brain contusions are wedge-shaped. Correct. Histopathology of brain contusions helps in dating the injuries. Yes, definitely. Regarding head injuries, raised intracranial pressure is associated with dural hemorrhages. Yes, it's correct. Space occupying lesions lead to midline shift. Yes, it's correct. Primary traumatic brainstem hemorrhages are seen in the periphery. So this is the clue. If this is the brainstem, if it is a primary impact, so that means injury is going to have at the time of impact, you get single, small hemorrhage towards the periphery of the brainstem. Whereas to that, in case of secondary brainstem hemorrhages or dural hemorrhages, you get central, large, multiple hemorrhages, and at times the distortion of the brainstem or pons can occur as well. So primary brainstem hemorrhages are seen in the periphery. Yes, it's correct. Secondary brainstem hemorrhages are multiple in number, correct? Contra-coup injuries are relatively larger than coup injuries. Yes, it's correct. Contra-coup fractures are observed in the occipital bone. It is incorrect. Hardly we know about occipital fractures or occipital brain injuries in the form of contra-coup type. Regarding concussion, concussion is a post-mortem diagnosis. It's correct. The reason is, by definition, it is a retrospective and clinical diagnosis. Compensation syndrome is identified, correct. Amnesia is a feature, correct. Anterograde amnesia is almost always present. It is not correct actually. Amnesia should be there to diagnose to severe kind of concussion. However, it is considered the retrograde amnesia is almost always present. There is structural damage to the brain. No, macroscopically and microscopically, the patient should be all right at the time of your examination. Loss of consciousness is immediate and transient. Yes, it's correct by definition. It's a retrospective diagnosis, correct? Categorization of hurt is endangering life. Yes, it's true. Because of the loss of consciousness, there may be the risk of asphyxia and aspiration. Concussion is considered a severe type of head injury. No, it is a milder form of head injury. Milder forms of concussion may pass unnoticed. That's true. As I have mentioned earlier, there are different grades of concussion. Usually we speak about severe form, that means cerebral concussion. So milder forms of concussion may pass even unnoticed without any period of loss of consciousness. Regarding concussion in medical legal practice, concussion is a clinical diagnosis, definitely. Concussion is frequently fatal. No, it is a milder form of brain trauma. Concussion is easily demonstrated during autopsy. No, we don't have any structural damage. It is just a functional derailment. Concussion is categorized as fatal involuntary cause of nature. It is incorrect. It is endangering life by asphyxiation, by falling the tongue back during the loss of consciousness, and also by aspiration of food. Post-concussive symptoms are essential for diagnosis or not essential. Concussion is a result of diffuse axonal injury. It is incorrect because we should not have any structural damage. The pathology is functional rather than structural. Yes, correct. Automatism has been recognized during concussion. It is correct. What do you mean by automatism? That means a person acts, that means talking, walking, but he is not under his control. That means his actions he is going to act without a clear conscious control on him. As a result, he might be accepted from the crimes or actions that he did during the period of concussion. Regarding traumatic diffuse axonal injuries, the mechanism is acceleration and deceleration, correct? Immediate loss of consciousness and a comatose state are features, correct? Penetrating gunshot injuries can result in diffuse axonal injury. It is incorrect. It is just penetrating type of gunshot injury, no acceleration or deceleration of the brain or head. Injuries are seen mostly in the white matter. Yes, axons are involved. Axonal bulbs in histopathology are indicative of diffuse axonal injury. It is correct. Regarding traumatic diffuse axonal injuries, DAI is a result of low velocity trauma. Incorrect. High velocity. Diffuse axonal injury primarily affects the grey matter of the cerebral cortex. Incorrect. White matter. Microscopically, there is axonal swelling. Retraction balls are visible on histopathologically. Yes, it's true. While now with the diffuse axonal injury, there may be axonal damage. So now, but still messages are coming like this, but messages can't go ahead because of the disruption. So what happened is their chemicals or proteins are going to accumulate here, and with histological staining you can see these proteins and chemicals as swelling or retraction balls. The special protein, beta amyloid precursor protein, can be seen especially with immunological stains like this. The distal part is going to get degenerated with Wallerian degeneration. Causes prolonged coma or persistent vegetative state, it's correct. Sudden prolonged loss of consciousness in road traffic accident or falls, it is mandatory to exclude diffuse axonal injury, yes, because this is the natural history. Both DAI and DVI are associated in a given case, yes, true. DAI is mostly a macroscopic diagnosis. So this is the explanation. DAI is mostly a microscopic diagnosis, especially in its acute form. And also, if the injury is so severe, we can see certain hemorrhages as well, as we have described during the theory part. So it is considered basically a microscopical diagnosis, but there are instances where we can diagnose macroscopically as well when it is severe or in delayed presentations at time. Caused by direct blunt impact rather than acceleration, deceleration or rotational forces, it is incorrect because we know it is actually caused by clearly acceleration, deceleration or rotational force. Regarding head injuries in medical legal practice, Konraku injuries are not seen in the occipital area. It is true. Konraku injuries are present only as soft tissue injuries. It is incorrect because we can see anterior cranial fossa fractures due to Konraku injuries. Konraku injuries are characteristically seen in moving heads. That's true because we need the mechanism of acceleration, deceleration and rotational forces. They occur diagonally opposite to the Ku injury. It's correct. In its occipital impact, you can get frontal Konraku injuries. In side impacts also, you can get diagonally opposite. It's not like this. You can have like this and also like this. So, this is correct. The mechanism of EDH is explained by the Konraku mechanism. It is incorrect. It is a fact. A mechanism of causation of a black eye is due to Konraku injuries. Yes, possible to have. Konraku injuries are typically seen in the frontal and temporal poles. It is correct. It is not only poles. We can see underneath as well because of the corrugated nature of the base of the skull as well. Infarction of the calcarine area of the occipital lobe is a feature of space occupying lesion. Yes, it's correct. Regarding meningeal hemorrhages in medical legal practice, EDH is the most common type. It is incorrect. The commonest type is subarachnoid hemorrhage because it is originated with natural and traumatic causes. EDH is most common in young individuals. That is true. The reason is in older individuals, the dura is tightly attached to the skull. Lucid interval is a known phenomenon in subarachnoid hemorrhage. No, it is mostly seen in extradural hemorrhage, but at times in subdural hemorrhage as well. EDH is almost always traumatic in origin. It is correct. Most cranial extradural hematomas are arterial in origin rather than venous. It is correct. Posterior EDHs are commonly arterial. It is incorrect because posterior extradural hemorrhages are commonly venous or dural sinuses, the source of origin. SDH is mostly arterial. No, it is venous with emissary veins. The presence of a small brown subdural hematoma with capsulation in sudden death due to acute myocardial infarction is an incidental finding. It is correct. The reason is in old age and in alcoholics, we see such a finding, the person is going to die with some other reason, such as acute myocardial infarction, but there may be incidental findings such as chronic or subacute subdural hematoma. Regarding subdural hemorrhage in medical legal practice, an acute subdural hemorrhage is a necessarily fatal injury. No, it can be treated. So it is not a type of necessarily fatal injury. Necessarily fatal means there are no treatments under the sun. The person is definitely going to die. It is origin in almost always from arterial damage, no, venous in origin. Bridging vein damage is due to rotational forces. Yes, true. Subacute SDH is seen around 2 weeks after the trauma. That is true. That is actually acute means up to the 3 days, and 3 to 3 weeks is considered as subacute. And if it is more than 3 weeks, it is going to be considered as chronic. So in this case, it is correct. Chronic SDH may rebleed spontaneously, correct? Association with a fracture is high, no, it is not. Association of a fracture is seen in extradural hemorrhage, but not in SDHs. Regarding space-occupying lesions and raised intracranial pressure, a space-occupying lesion is any abnormal mass in the cranial cavity that exerts a pressure effect on the brain. Yes, correct. An EDH acts as an SOL when sufficiently enlarged. Yes, that means small EDHs may be symptomatically managed as well rarely, but it has to be large enough to have a pressure effect. Raised intracranial pressure result in primary brainstem hemorrhages. No, it should be secondary. So this is incorrect. Midline shift is characteristic of a unilateral space occupying lesion. Yes, correct. Raised intracranial pressure creates a vicious cycle that leads to further effects. Correct. In tonsillar herniation, the cerebral tonsils herniate through the superior orbital fissure. It is incorrect. It is through foramen magnum. In subfalcine herniation, the cingulate gyrus herniates through the foramen magnum. It is incorrect. It is herniates under the falx cerebri. Space occupying lesions decrease intracranial pressure because the skull can expand to accommodate the mass. It is incorrect. It is increased here. Raised intracranial pressure caused by a space occupying lesion can lead to internal hydrocephalus. Yes, it is correct. Regarding membranal hemorrhages in medical legal practice, subarachnoid hemorrhage can be caused by both traumatic and natural causes. True. Ruptured berry aneurysm causes a thick basal subarachnoid hemorrhage. True. CV1 syndrome describes damage to the vertebral artery leading to fatal subarachnoid hemorrhage. True. That means whenever you get any rotational or hyperextension of the neck, there may be a rupture of the vertebral artery at the cervical vertebra 1 level, leading to fatal subarachnoid hemorrhage. CV1 syndrome is caused by a blow to the neck. Yes. Focal subarachnoid hemorrhage is characteristic with cortical contusions. Yes, it is true. Subdural hemorrhage is a feature seen in shaken baby syndrome. Yes, because of the rotational and acceleration deceleration due to the shaking effect of the baby. Yes, subdural hemorrhage is a known thing. It is actually a syndrome where you get brain edema or encephalopathy, subdural hemorrhage and retinal hemorrhages. Thank you very much.